This is part 1 of my talk about diuresis renography. The aims of this talk are to explain the purpose of diuresis renography, to describe how to perform diuresis renography and how to interpret the results, and then to compare diuresis renography with the calculation of mean transit time using deconvolution. In part 1 I'll give an introduction and remind you what a renogram is. Then I'll talk about PUJ obstruction, that's Pelvi-Ureteric junction obstruction, and discuss some of the possible investigations. In part 2 I'll talk about the principles, describe kidney transit times and the effect of frusemide. Then in the third part I'll go on to talk about practicalities, describe the diuresis renography protocol, how to interpret the results and give some examples. And then in part 4 I'll compare diuresis renography with deconvolution, discuss which method to use, talk about the timing of frusemide and the dose of frusemide to use. So let me start with a refresher about kidney anatomy. If we look at a cross-section through a kidney, we can see that the outer part here is the cortex, and within that there's an area known as the medulla. The cortex and the medulla together are known as the parenchyma. They contain the functioning part of the kidney, which contains the nephrons from which the kidney is made, and the nephrons comprise the glomeruli, the tubules and the collecting ducts. Within that there's an area including the calyces and the renal pelvis, which together form the collecting system. So when blood enters through the renal artery, it goes out through the distribution arteries out to the cortex, where it's filtered by the glomeruli, and the filtered blood passes out again through the renal vein. Meanwhile, the filtrate, which is going to form the urine, passes down through the renal tubules, down into the medulla, back out again to the cortex, and then collects through these collecting ducts, and the collecting ducts from many different nephrons gather together to form eventually the calyces, where the urine from all the nephrons is gathering together through the calyces and the renal pelvis before the urine eventually leaves down the ureter. So let me remind you what a renogram is. The renogram is a diagnostic nuclear medicine procedure to investigate kidney function. The patient is positioned in front of a gamma camera, seated or lying down, so that we can get a posterior view of the kidneys from the gamma camera. Then we inject a suitable radiopharmaceutical, which is a radioactive tracer that is excreted in the urine, and because of the radioactivity the gamma camera can watch it pass through the kidneys and on into the bladder. We acquire a dynamic study, typically one image every 20 seconds for about 30 minutes. Then we analyze those images using a computer to produce curves showing how the activity in the kidneys and bladder changes with time. And the renogram curves which we get demonstrate kidney function. They show both uptake by the kidneys and also elimination into the bladder. So here's an example of a renogram. We can see some images here showing early images moving through 30 minutes as time goes on, and you can see here the left kidney, which starts off with plenty of activity, and as time goes on the activity in the left kidney gradually disappears because it's moving on into the bladder, which we can see filling at the bottom of the image here. The right kidney has less activity early on, and indeed look at the images, you see that the activity there gets more intense. So we draw a region of interest around the left kidney here in blue. We see that the curve for the left kidney shows the activity increasing with time up to a peak at about 3 minutes before it comes down and it empties quite quickly. However, the curve for the right kidney from this region of interest here gives the curve in red, which rises less quickly than the left kidney, indicating that there is less activity, less function in the right kidney. And indeed, the computer says that there's only 20% of the total function in the right kidney and 80% for the left kidney, as evidenced by the lesser slope of the right kidney compared with the left in the first few minutes. Not only that, the right kidney doesn't empty at all. The activity in the right kidney goes up and up and up and continues to go up even after we administer a diuretic of furosemide. So the right kidney in this patient clearly has worse uptake, and it also fails to empty. So one reason for a renogram curve like that which doesn't empty is a condition called hydronephrosis. That really just means an enlargement, a dilatation of the kidney collecting system, that is the calyces and the renal pelvis. On this intravenous uregram, which is an X-ray study, you can see contrast collecting in the pelvis of this kidney, and you can see it's a very large dilated renal pelvis. That's typical hydronephrosis. It's a common renal problem. It may be congenital in children from birth, or it may develop later in adult life. But it's not necessarily obstructed in the sense that urine can still pass through. It may just be a rather large volume renal pelvis, so urine can still flow normally through it, but it just takes longer to empty because there's a large volume in the renal pelvis, and that could be why the renogram curve takes a long time to empty. It could be, on the other hand, what we call a PUJ obstruction, a Pelvi-Ureteric junction obstruction. In this case, urine has difficulty passing from the renal pelvis through the PUJ here and down into the ureter, and that could be why the kidney fails to empty on the renogram. That can cause a build-up of pressure in the kidney, which can damage the kidney, and also, because urine flows rather less quickly, the stasis can lead to infection. So a patient like that with an obstructed system may require a pyeloplasty operation to relieve the obstruction and let the urine flow normally. So let's consider some of the causes of a dilated renal pelvis. It may occur secondary to some physical obstruction, something that could be external outside the kidney, like an aberrant artery that is compressing the ureter, or maybe previous surgery which has damaged the ureter in some way. Or it may be something internal to the kidney, for example a stone that has lodged itself in the renal pelvis. Now, nuclear medicine is not generally particularly interested in these physical obstructions. We're generally interested in a functional obstruction, which is what I would call a primary PUJ obstruction. This can occur if we've got abnormal musculature in the renal pelvis. For example, if the muscles are thickened, they may make the narrowing of the ureter at the PUJ, or maybe they've lost their contractility, so they're no longer letting peristalsis conduct the urine through the PUJ. Or it may just be that there's an abnormal shaped renal pelvis instead of the nice cone shape which channels peristaltic waves down through the pelvis, through the PUJ and into the ureter. If it's an abnormal shape, the peristaltic waves may not be effective in conducting the urine down into the ureter. Now, this is likely to result in a high pressure system, and that sort of patient may require a pyeloplasty operation, which will be able to remove the affected section of the muscle or reshape the renal pelvis in order to let the urine drain normally. That will relieve the pressure and that avoids damage to the renal tubules, which can occur if the pressure is left for too long. On the other hand, it may just be a not obstructed system. Maybe the patient has some reflux which has dilated the renal pelvis, or they've had an old obstruction like a stone which has now been relieved. So in that case we're left with a hypertonic renal pelvis. That simply means the muscle has lost its tone, it's more relaxed than normal. Now that will result in a low pressure system. It's not going to damage the renal tubules, therefore the patient doesn't need an operation. So let's just say a little bit more about Pelvi-Ureteric junction obstruction. if we look at the renal parenchyma, which is the cortex and the medulla around the outer part of the kidney here, that contains the renal tubules, which are long, narrow tubes, and the renal radiopharmaceutical will typically take about 2 minutes to pass through those tubes. That's the parenchymal transit time for a normal renogram. The collecting system, however, which consists of the renal calyces and the renal pelvis here, is a mixing chamber effect because it has a fairly large volume. So the transit time there depends on the volume and on the flow. So in a normal kidney, which has got a quite small volume renal pelvis, it'll empty quickly because it doesn't take very long for the renal radiopharmaceutical to pass through that small volume. However, in a hypotonic system where we've got the loss of muscle tone, and so the pelvis will expand and become dilated, that's the condition that we call hydronephrosis. It's a low pressure system, it's not going to cause any damage, but because the volume is large, the pelvis will be slow to empty because of simply of the mixing chamber effect in the large volume. But if we give the patient a diuretic, which increases the urine flow rate, the pelvis will empty normally despite the large volume, because the high flow will flush it through quite quickly. On the other hand, in case of PUJ obstruction, where we've got a constriction or some abnormal vessel or loss of peristalsis at the PUJ here, that has a high pressure, and that pressure will of itself lead to a dilated renal pelvis and give very slow emptying for that kidney. And if we give a diuretic to this patient to try to increase the flow rate, the kidney like that with its obstruction won't be able to cope with the high flow, so the pelvis still doesn't empty. So diagnostically, if we want to distinguish between the hypotonic system, which is not obstructed, we can see that's got a large volume but a low pressure, and the pelvis is slow to empty at normal flow rate, and if we give a diuretic, it empties normally. On the other hand, the obstructed system, which has a large volume but a high pressure, it's very slow to empty also at normal flow rate, but if we give a diuretic, it still doesn't manage to empty that obstructed system. So we can use the administration of a diuretic to distinguish between the not obstructed and the obstructed system. So I've got a little demonstration to illustrate that using some balloons as a model. I'm going to use these balloons to illustrate what happens in the renal pelvis of a kidney at different urine flow rates. This green balloon represents a normal renal pelvis. It's a small volume, and I'm going to blow through it to represent urine passing through the pelvis. So I've cut a little hole at the end of the balloon to represent the Pelvi-Ureteric junction where the urine can come out into the ureter. So if I blow at a normal flow rate, we see we get a small volume system, and I don't have to blow very hard. There's not much resistance there. It's a low pressure system. And I can increase the flow rate, representing a diuresis, and you see we still get a small volume and very little resistance, so it's still a low pressure to get the flow through that normal renal pelvis. Now, unfortunately, the balloons are not a perfect model of the renal pelvis because in the real renal pelvis, urine is propelled through by muscle peristaltic waves contracting to force the urine through the pelvis and down the ureter. My balloon doesn't have anything of that, so the model is not perfect, but it illustrates the principle. So if we come to this red balloon, this is going to represent an obstructed system with an obstructed Pelvi-Ureteric junction. To demonstrate that, I've had to make the hole representing the PUJ much smaller in this one, so it represents a physical obstruction. In a real Pelvi-Ureteric junction obstruction, it's much more likely to be a lack of function rather than an anatomical one like this, but that's the best I can do with these balloons. So if I blow at a normal flow rate, you see we get a larger volume, and I had to blow harder. The pressure went up because of the resistance to flow. That's why the volume went up as well. So this is already a slightly higher pressure system. But if I illustrate what happens with the diuresis by blowing faster, you see the volume goes up even more and the pressure goes up correspondingly. So I had to blow quite hard to get a high flow rate past this obstruction. And that's typical of what happens in an obstructed system. As you increase the flow, the volume goes up and the pressure goes up. And in fact, we never produce quite such a high flow rate as we did with the normal system. But it's also possible to have what we call a hypotonic system, one where the muscles in the pelvis have no tone at all. So I'll illustrate that. Instead of the flexible elastic of the balloon, I've got a rather flaccid plastic bag here. Again, it's got a hole in it representing the PUJ. And if I blow through this at a normal rate, we get a large volume but a low pressure. And if I increase the flow to represent a diuresis, again the volume stays large, the pressure goes up a little bit, but it's not unduly high. So this is a low pressure, non-obstructed system. It's got a large volume but a low pressure. This is a large volume obstructed system. It's characterized by a high pressure, and the pressure goes up even more with increased diuresis. And this represents a normal pelvis, which is a low pressure system. So the normal pelvis has small volume and low pressure. The obstructed one has a large volume and high pressure, and the hypotonic one has a large volume but low pressure. So that's how we can distinguish between the three systems. So let's look at some possible investigations that can be used to investigate patients with suspected PUJ obstruction. An ultrasound scan will easily demonstrate whether a patient has got a dilated renal pelvis. So it can see physical causes like a stone, for example, but it can't demonstrate whether there's any functional obstruction. So it doesn't distinguish a truly obstructed system with a high pressure because it can't measure the pressure in any way. The intravenous urogram, the IVU, is an X-ray study with iodine contrast, like the images that I showed earlier. That has the same limitations as the ultrasound. It can demonstrate physical obstruction, but it can't demonstrate functional one, so it can't really say whether it's truly obstructed, even if a stone is there, because it doesn't know what the pressure is. The IVU has been superseded by the modern equivalent, which is the CT urogram, which gives good three-dimensional anatomical information, so it can also nicely demonstrate pelvic dilatation, but it's only going to show the physical obstruction if there is one. It won't show anything about a functional obstruction. It has no way of knowing what the pressure is. It's not really a dynamic study. You may take 2 or 3 snapshots at different times, but it doesn't really show how things change with time. The urologist's approach, though, is much more direct. They do a real dynamic study. The pressure flow study, developed by Whittaker in 1973, is performed by taking a percutaneous needle inserted through the patient's back into the renal pelvis, and then infusing saline down through that needle at increasing flow rates, and measuring the increase in pressure as you do so. If the pressure doesn't go up very much as you increase the flow rate, then it's a low pressure non-obstructed system. If the pressure goes up significantly as you increase the flow rate, then it's a high pressure obstructed system. So this really does measure what we need to know, the pressure, which the other imaging studies don't do. But it's clearly a research investigation that is not going to be used routinely in every patient with suspected PUJ obstruction. So let's see what nuclear medicine investigations are available to diagnose PUJ obstructions. Well, the standard renogram can be useful because it naturally quantifies renal function, and it's important to monitor renal function in these patients to make sure their function isn't falling off. However, what we really want is something that will tell us that a kidney is at risk before the function starts to deteriorate. The standard renogram will demonstrate that a patient has got a dilated renal pelvis, because if the renogram curve doesn't fall, the kidney isn't emptying, and that's likely to be due to a large volume dilated pelvis. But it doesn't indicate the cause. It doesn't tell us whether it's a high or low pressure system. So in 1978, O'Reilly developed the diuresis renogram. By giving the diuretic furosemide during the renogram, this was an attempt to overcome the retention in a dilated renal pelvis. It doesn't measure pelvic pressure, but it does infer an increase in pelvic pressure from the response to the furosemide. Because if the renogram curve empties after the furosemide, then it's clearly not obstructed and it's a low pressure system. Whereas if it fails to empty after furosemide, this infers that it's an obstructed high pressure system. But Britain at the same time developed the idea of applying deconvolution to the renogram. This is a mathematical technique which allows you to calculate the parenchymal transit time. This doesn't measure the pressure, but it also infers that if you've got a prolonged parenchymal transit time, then this implies that there is increased parenchymal pressure, and that is therefore an obstructed system. Now, in another talk in this series about renography, I have explained deconvolution of the renogram in some more detail. So this talk now that I'm giving is more about diuresis renography, to say a bit more about that and to compare it with deconvolution. So you can see that the two techniques were developed at about the same time. Keith Britton was consultant nuclear medicine physician at St Bartholomew's Hospital in London, and he was an acknowledged expert in renography. So he and his team developed some very nice techniques for calculating parenchymal transit time by deconvolution of the renogram, and using that to diagnose suspected Pelvi-Ureteric junction obstruction. Meanwhile, Paddy O'Reilly was a urology registrar in Manchester Royal Infirmary, and he and his colleagues developed the technique of diuresis renography. So Paddy became not only a successful urological surgeon, but also an international expert on the subject of diuresis renography. So in the 1980s, I remember there were often lively debates at nuclear medicine meetings about the relative merits of the two techniques, as both authors presented their latest papers. So what I want to do in this talk is to try to compare the two techniques, although I must admit that I'm not entirely impartial on this matter, because in fact my first job in nuclear medicine was as the physicist providing scientific support to Paddy in Manchester. In fact, we were both funded by the Manchester and North West Kidney Research Association specifically to develop renography techniques. So I was part of the Manchester team that developed diuresis renography. In fact, I continued working in Manchester for nearly 40 years after that, and I maintained a particular interest in renography. So what I'm going to say in this talk is very much influenced by the Manchester point of view. However, I hope that I have been fair to Keith Britton's methods, so that you, the listener, may be able to judge for yourselves. So that's the end of this introduction. In the second part, I will go on to explain the principles of diuresis renography.